Well, talking about the most common motor dysfunction in pediatric population, pediatric cerebral palsy. Starting with a case of an 8-month-old baby girl who doesn't sit or roll and favors right hand. So here you can see a delayed milestone because at 6 months we expect the babies to sit alone and roll. And then she favors the right hand, which means that one part of the body is functioning better than the other. So what is cerebral palsy? It's in short the maldevelopment of the immature brain. Interestingly, the lesions in the brain are not progressive, but their functions may change over time. Why it's very important? Because it's the most common motor disability in childhood. We want to diagnose it as soon as possible to interfere and have better outcomes. It appears 1 to 3 per 1,000 births. And the risk factors, if we want to break it down, it's either the maldevelopment of the brain, the vascular impairment, or the hypoxic events that happen to the brain leads to maldevelopment or lesions in the brain, which supply our whole body with the nervous system. So prematurity, very low birth weight, perinatal asphyxia, which means that some parts of the brain are not getting enough oxygenated blood as much as they needed, congenital brain malformation, strokes in the neonatal period, especially if the parents have any history of thromboembolic events, infections like toxoplasmosis or cytomegaloviruses, and some genetic and metabolic conditions can lead to this. I want to add one more point here is the hyperbilirubinemia, which can cause kernicterus in the neonatal period, where the bilirubin can accumulate in the basal ganglia and may lead to cerebral palsy as well. The pathophysiology really depends on the time of injury. So that's why it's very important to understand if the baby was born preterm or in their term time. Injuries in the preterm period often affect the periventricular white matter. White matter is the thing that regulates the electrolytes and the impulses between the brain regions. So if it's affected, it may cause spastic diplegia, while in term injuries, it may involve the cortical or basal ganglia, which may lead to hemiplegia or dyskinetic cerebral palsy. You can even classify it by motor types or distribution types. Classifying it by motor types will be spastic, which is the most common, dyskinetic, where you have dystonia, which is the involuntary movement or contracture of one part of the body, especially the neck, ataxic, or you can even have them mixed and matched. If you want to classify it by the distribution, you have hemiplegia when one side of the body is functioning well while the other one is not, diplegia when the legs are affected more than the arms, and quadriplegia when all the limbs are affected. Here's a table that if you want to check it in details, you can go back to it. But when such a patient comes to our clinic, we want to classify these patients in a more detailed and informative way. So we use a gross motor function classification system. You can check it out by only typing GMFCS to your Google or check out the neurologic books. It describes the mobility and predicts the function over time. So it gives us more information about the prognosis of this disease or in case of our patients. It's way more useful than the muscle tone alone for planning intervention. What are the early warning signs? The asymmetry, the poor head control. Again, the milestones are very, very important in motor disabilities. Persistent primitive reflexes, stiffness or hypotonia, delays in the milestones like crawling and sitting, and abnormal hand use. You can use 2 scales in the infancy period if you want to detect it faster: Hammersmith Infant Neurologic Exam or Alberta Infant Motor Scale. Both are available on PDFs in the Google Chrome, or even you can check them in the neurology books as well. What are the red flags? When do we suspect cerebral palsy? When you have delayed motor milestones. That's why we have to check milestones every time a pediatric patient admits to our hospital or our clinic. Check for the tones and movement. You have to check the persistent primitive reflexes. That's why we have physiologic time of appearance and disappearance of the reflexes. lack of progression in motor skills. For example, if the baby started walking at let's say 24 months, but they're not running yet for like even if they're in their 5 years of age. History of neonatal injury is again very, very important. So let's say a patient that has these things like delayed motor milestones, or like apathic, or they favor one hand more than the other. What do? You first take a focused history. Prenatal exposure, it's very important. You have to ask the mother about any radiation or infection or bleeding events that happened throughout the pregnancy, birth events during the birth, what happened, any hypoxia, any bleeding against, any trauma happened to the baby or the mother. Neonatal course, if the baby had any hyperbilirubinemia or infections by that time, or had to stay in the nursery for some time. Family history, again, it's very important to record any genetic, metabolic, or thromboembolic diseases runs into the family, and detailed developmental milestones. When did the baby hold their hand? When did they smile? When did they stare at you? After taking a very detailed history, you have to move on to perform a structural neuro exam. What do you have to check the most? The tone, the reflexes, the asymmetry, and functional skills. So let's say you took all that thing. You want to know what to investigate or what to order first. You have to first order a brain MRI to detect if there is any lesion in the brain, and if it is, where is it located, to suspect which parts of the body are really affected, and predict the prognosis. Then you can order an EEG to check if there are any seizure or epilepsy. If the brain MRI is important, then you can move to metabolic and genetic tests. And after doing that, you can assess vision and hearing by referring the baby to ophthalmology and an ENT doctor. Sadly, there is no cure for this disease yet, but the management has to be multidisciplinary to optimize the functions and prevent the complications. There are non-surgical therapies, starting with the physical therapy. It's very, very important for these patients to have physical therapy applications to promote the motor skills. And it's very important to have respiratory physical therapy, because it decreases the readmission times of these patients. It helps them with their secretion, with their sputum, and the movement of their muscles, and prevent thromboembolic events as well. There is something that is very, very important, and I nearly saw it in many of the patients that we had to hospitalize. It's real pictures from real patients that I've seen in my hospital. Spasticity and focal contractures. In this case, what do? We use botulinum toxin injections, or even oral agents like baclofen or diazepam. Sometimes we even use intrathecal baclofen to make it go directly to the central system and make it more effective. For dystonia, we use tetrabenazine or gangliosides. Sometimes we consulate these patients to orthopedics for tendon lengthening, muscle releases, or osteomies to treat fixed deformities and improve their gait. Selective dorsal rhizotomy is rarely applied, but it may be considered in carefully selected spastic children to reduce tone long term. So what are the comorbidities? Again, from my experience, I can tell you that these patients often admire to the hospital with seizures, respiratory problems, and gastroesophageal events. What do we do if the patient is having gastroesophageal reflexes? You have to start anti-reflux treatment like Gaviscon and so on, antiemetic medications, or even insert the nasogastric tube and feed them with it to avoid aspirated pneumonia. And for sleep and chronic pain, which are again very frequent comorbidities, you can use sleep medications like melatonin and analgesic to take the pain under control. They require screen and treating recurrently. After predicting the prognosis, and that's when you examine them in a very detailed way and put them on their scale of the GMFCS to see their functioning and brain MRI. Provide an honest, individualized counseling with the parents and connect them to support and peer groups. Finally, if you have any questions or if you have any comments that you want to say or add, please write them below. I hope that this video was useful and informative. Thank you for watching.